Oh, sir. Good evening, everyone. As a part of continuing medical education, regular CMEs, today we are also going to organize very interesting, I would say, webinar. And this is organized by National Heart and Lung Society. And this is the second webinar so far after the lockdown. And today I am extremely pleased to welcome all the speakers and especially my teacher and guru of the guru, Professor S. Guru Prasad, and similarly other speakers which I'll be telling you. And to start this webinar, I would first request Professor Dr. Samraj Regmi to session this webinar as a chairperson, and I would also request him to highlight something about the National Heart Lung Society by providing some information, and welcome all the speakers.
Thank you, Dr. Shankar. First of all, I would like to thank all of the immediate speaker, and the participant of this second webinar or Zoom meeting organized by our society, Heart Lung Society of Nepal. This society was established 3 years back at June 2017. After that, we are doing regular academic programs like CMEs, and sometimes those outside the health camps with the help of some international team, especially from the Czech Republic. We are doing health camps. With the support of them, we also doing the certain free health surgeries as well as the free PTMCs in our centers as well as in the Syed Gangalal National Heart Center. So our activities are basically focused on the Chittagong and surrounding districts. Till now, we are planning to expand our area beyond this in the future. Regarding the CMEs, since from the beginning, we are doing regular CMEs monthly before the Corona crisis. After this Corona crisis, we decided to, actually we are planned for the conference in May, but because of the Corona, last of the April or May, but because of this Corona crisis, which postponed it, I don't know whether when we are going to do this postponed meeting. Before this, we are doing this regular CME and Zoom meeting. We are started, and first webinar meeting 15 days back, which was already we did, and it was with a grand success. And now we are planning this second meeting today, and we are planning, if possible, in every 15 days, like such type of meeting. Where in this meeting today, we have the 3 prominent speakers. Regarding the speakers, Dr. Shankar will tell later on. The mainly focus, the topics are about the approach of arrhythmia by the eminent Professor S. Guru Prasad. And second topics is about the invasive cardiology, minimal invasive cardiac surgery, what can be done by the Kaushal Tiwari. And the third topics will be delivered by the Dr. Chandramani Adhikari, the congenital and structural intervention in Nepal and present future. So with this brief introduction, I like to request Dr. Shankar to further continue the meeting.
Thank you, Dr. Sam. Now I would like to invite the first speaker, is Professor Dr. S. Guru Prasad. I think he does not need introduction to many of the students in Nepal and India, but anyway, for those who may be meeting him for the first time, I'd like to inform that he is a senior interventional cardiologist and electrophysiologist, and he is the head of cardiac electrophysiology, arrhythmia services and device therapies. He is working recently in Mayut International Hospital, Chennai, India, and he is the professor in cardiology of College of Medical Sciences, Kathmandu University, Nepal. Similarly, he is a visiting professor in Timsa, Sakopa University, Japan, and he is the chairman of National Arrhythmia Council, and he is very dedicated to research, and he is a research member in Hope Asia Network for Hypertension, and he has many years of experience, more than 25 years of experience in internal medicine and more than 15 years experience in cardiology, and I'm also one of the DME student of Dr. S. Guru Prasad. And we really get such a great teacher.
Thank you.
He does not have only the education, but he knows how to imprint the facts, usually the medical or cardiological facts, to the students. And what the students need to understand is he really targets to that point. And I really appreciate this one. And with this, I'd like to invite my professor for his presentation.
Thank you. Thank you, Shankar, and thank you, colleague speakers, and maybe other doctors and dear students. A warm good evening to you all, and hope you're all doing and staying safe in this corona pandemic. And I wish you all the safe health, long life. And maybe I tried within these 30 minutes, I try to summarize, give a glimpse of approaching arrhythmias. So at the end of my talk, if you're able to recognize that this is an abnormal rhythm and this needs special attention, and at least this is supraventricular arrhythmia, this is ventricular arrhythmia, what is fatal, what you can manage. If you understand this, I think my job is done. So simple, okay. So probably every one of you may have to deal an ECG every time, because I think the domain belongs to every specialist. Forget specialist, every doctor, okay. So because you may be a surgeon, anesthetist, even a gynecologist, dermatologist, because it's all one body. So, and every fitness, every system needs adequate cardiac function. So everyone, any basic doctor needs the basic knowledge about an ECG, and because that's why it is taught in the first year of medical curriculum. Okay, so I tried to be precise, try to be focused, because I cannot cover every topic in the ECG, but let me try to do my best. Okay. So this was my postgraduate update book, Cardiology Clinics, and the chapter, editor by Serge Berold, and very famous icon in electrophysiology. And the first chapter is written by Hurst. So the godfather of, it's one of the Bible for a cardiology student, all cardiologists all over the world, the textbook by Hurst, cardiology textbook. So he mentions about two words, competence versus pretense. Competence is, yes, you can do, you know what you're doing. Pretense is, you do it, but you don't know what you're doing. So I feel that it is a fact in the medical curriculum, or to many doctors, we know how to take an ECG, but we cannot interpret properly, appropriately to the situation. So two words I'm using, proper and appropriate. Proper interpretation of the ECG that is appropriate to the existing clinical situation is very important. So it is not pretense. Pretense is acting that you know something, but actually you don't. So from pretense to competence, it's what is important. You need not be masters. I like bike racing. This was in, I don't know, maybe Hong Kong or Bangkok, or some small distance bike riding. You need not know the complex engineering mechanisms of the sports bike. If you know how to ride safe, you can get away with your life. Similarly, ECG doesn't need, you need not be a cardiologist to understand an ECG, but as a basic doctor, if you know what is normal, what is abnormal, and what is potentially lethal, this is enough for your level, okay? So the rest, maybe if you're a cardiologist or physician really interested in cardiology, you can really go to an extent. This is the basic slide. In every talk I show, never interpret the ECG alone. One ECG may be normal for a situation. The same ECG can be fatal in another situation. So interpret the ECG for decision making. For decision making, ECG interpretation should be with the clinical context. Never forget this basic. And I hope all of you remember the basic portrait of the ECG rhythm strip and ECG. morphology, PQRST, because I can teach you basics now in half an hour. Because I presume that all of you are well versed with the normal pattern of ECG. Remember the basic waves, P and their contours. The wave, the shape, the contour of the wave, and the normal intervals. So like PR interval, QRS duration, QT interval, okay, and this ST segment. So this should be in your mind. You know abnormal when you know what is normal. So never forget the normal contour and pattern of the ECG, okay? Right, so all of you know the basic conduction system of the heart, right? So you have SA node, you have the headmaster of the conduction system, and maybe in charge AV node, and the potential, I mean the definite fibers. So they are all atrial myocardium. There are no specific channels between AV node and SA node and AV node. But from the AV node, you have his bundle, right and left bundle branches, and then the fascicles. You have potentially anatomically defined existing conduction system in the heart, starting from the AV node down to the Purkinje system. Okay, so the chief headmaster and the pacemaker of the heart is a node, and then that supplies, that is the rhythm. That's why, because it gives the rhythm, the normal rhythm is called as sinus rhythm. Because sinus rhythm is physiological, it lasts, it gives longer life to your heart and to your life, and it is more physiological. It gives more blood volume, more stroke volume, and real maximum output when the sinus rhythm works. It is the sinus beat that gives the maximum output physiologically. That's normal, okay? So next, remember, the whole atrium is activated once, at one, like a waterfall. It comes from up to down, SA node to AV node. From the atrium, ventricles, they are not activated directly. The whole activation of the atrium gets converged onto the AV node, and then only AV node allows the activation to go to the ventricle. The AV node and the his bundle. This is known as AV junction. Okay, so this AV junction, his bundle, giving rise to right and left bundles. This is the highway that an electrical impulse traverses from the sinus node to the AV node, and from the AV node, it is channelized. So atrial activation is like a waterfall, but all the water concentrates at the AV node, and this electricity in the pipelines, in the cables, is channelized. Please remember this. So that is why ventricles are activated by only the conduction system. Atrium is activated by sinus node to the myocardium. Whole myocardium is activated. You don't have any special fibers. The myocardium is like a fire. It is like a forest fire that activates the atrium. Whereas the ventricles, they are activated by the conduction system, not by the muscle to muscle. Okay? This conduction system, specialized conduction system with his bundle branches and Purkinje fibers. This conduction depends on the size of chambers, supply, speed, and okay, this is the basics. And remember, what is the source of arrhythmia in the heart? Any structure except the fibrous skeleton. Except the fibrous skeleton, which doesn't have a myocyte. Wherever there is cardiac myocyte, there you can have arrhythmia. Any cell in the heart, any myocyte can give rise to an electrical activity and arrhythmia. Okay, so the most common arrhythmias are due to, I think you know the basics, automaticity, triggered activity, and re-entry. Re-entry is the most common mechanism of sustained arrhythmia. So these are the basics. Now enter the dragon, the main fight. So okay, look at this ECG. Concentrate, because I'm dealing with the case scenarios. You need not be bored. Okay. So this is the ECG. So a constable who was recruited for the airport security, he was referred to me because his ECG was found to be abnormal. He came for cardiac evaluation. That's his ECG. Because there is no direct audience here, I cannot ask you the questions. But look at this ECG. What is happening? There is some irregularity in this ECG. Like So there is some short RR interval, long, short, long, short, long. Look at this. There is a phasic variation of these pauses. Okay. And it is not all of a sudden. And all the beats are sinus. Okay. You look at the P waves of every beat. And QRS is normal. No interval is changed except this phasic variation of RR interval. What do you think it is? So it is actually an arrhythmia, but not pathological arrhythmia. It is a physiological arrhythmia known as sinus arrhythmia. Okay. Phasic respiratory variation will gradually increase and decrease the heart rate. So during inspiration, heart rate increases. During expiration, heart rate decreases. This is normal, absolutely fine. And it's a good sign of healthy heart. Sinus arrhythmia in an young man. Sinus arrhythmia in an young man is a sign of healthy heart. It is not at all abnormal. What you have to do is just reassure and send the patient. Okay. So another young lady with palpitation. What is happening here? Another young lady with palpitation. So normally you know the heart rate. Normally the heart rate is 60 to 100 beats per minute. How much is the heart rate here? It is almost 140. It's almost 130 to 140 at rest, because ECGs are taken at rest except during treadmill. So this is, so look at, that's why I said this is sinus tachycardia, but why it is due? Because that was referred as SVT to me. If you examine carefully, simply you can't, any doctor can't miss it, whatever specialty you belong to. This is goitrous hyperthyroidism. Okay, goitrous hyper, toxic nodule. Simply give a beta blocker and refer to a specialist, maybe a surgeon or an endocrinologist. Okay, so this doesn't need anything. Maybe you can because if beta blockers are good for this, you need not treat that arrhythmia specifically for the arrhythmia pattern. It is just because of secondary causes. All these are important when you're interpreting the ECG and for decision making, very important. So this old lady was referred for spine surgery and cardiac fitness. What is happening here? There is no P wave. There is no P wave. So there is no P wave at all. This is junctional bradycardia because there is no sinus rhythm. It is not even junctional because you see this. It is actually right bundle branch pattern. So there is no sinus beat. So sinus node is not working. Okay. If sinus node is not working, next level, if dad is not there, mom should head the family. So if SA node is not there, AV node should head the family. So there should be junctional rhythm. If I say junctional rhythm, still that should be narrow QRS, not like this. This is a wide QRS with bundle branch block, right bundle. So AV node is also gone. So this is right bundle branch pattern. So that means right bundle is also gone. So only the impulse source is, the pulse is given by the left bundle here in this patient. Left bundle is the cause of this rhythm. Because left bundle is giving the rhythm, it looks like right bundle branch block. Okay. Right bundle branch block means left bundle is giving the rhythm. Okay. So both SA node is gone, AV node is gone, and one bundle is gone. So this patient, if it is not due to dyselectrolytemia or other potent suppressive drugs, this patient actually spine surgery, he was bedridden, so that is why patient was asymptomatic. So when before giving the fitness of surgery, I've implanted the pacemaker in this patient. So this is an absolute indication for pacemaker. So most of the conduction system is gone, degenerative conduction system at this age. So this is degenerative conduction system disease with an escape rhythm from the left bundle. Okay. So it is not just diagnosing bradycardia and the ECG, you can infer a lot. Okay. So again, one more ECG similarly. So there is bradycardia. Definitely it is not sinus rhythm. There is no P wave. And look at the V1, same rhythm like right bundle. right bundle pattern. So left bundle is giving rhythm. Okay. But this patient, as soon as we gave atropine, this is what you should do when there is symptomatic bradycardia. First thing you should do is admit, monitor, and give an atropine. As soon as you gave atropine, patient picked up the rhythm. So the first instance, the first ECG, this ECG is the result of degeneration, whereas the similar ECG is a result of this. See the creatinine, significant hyperkalemia, creatinine and potassium. So it is not just cardiac cause that you need to think of every time. Every patient, every bradycardia patient need not require the pacemaker. So you correct the dyselectrolytemia, high potassium, patient will be back soon. Okay. So what is happening here? Diabetic with chest pain, ST elevation, anti-wall MI, but what else? Definitely there is a prolonged PR interval. Remember one box, this box, which is equal to 200 milliseconds. I told you, I assume all of you know the basics of ECG, then only you can understand these arrhythmias, okay? So, the normal PR interval should confine to one box, okay? So this is little prolonged. So what do you call this? First degree AV block. First degree AV block. But you see, every PVA, look at the rhythm strip. So the other diagnosis is definitely it is anterior wall MI, STEMI. But what else is happening? There is definitely prolonged PR interval. Prolonged PR interval with one-to-one conduction. You call this as first degree AV block. First degree AV block means, please remember, all P's go to V, that is all atrial beats go to ventricle, but with delay. The normal delay is normal PR interval, but every P wave goes with little late to the ventricle. So that's why prolonged PR interval. But remember, 100 P waves, 100 QRS. Every P wave is being carried to the ventricle. So there is one-to-one ratio between P and QRS. Okay, so that is known as first degree AV block. Look at this man. So what is happening in this rhythm strip? Patient actually came to me with chest pain. I told him go to the emergency if you have chest pain. He went to emergency room and then collapsed. So rhythm strip is showing ventricular tachycardia with shock, and slowly he regained rhythm. And this is the ECG after shocking. So what is the interpretation? Look at this, inferior leads. Inferior leads, ST elevation. This is acute inferior wall MI. Anything more? If you observe carefully the rhythm strip, there are some gaps, some pauses here. So you want to know why the pause is due to? If you analyze the rhythm strip carefully, this is the normal PR interval. There is inferior wall MI, no doubt about it. This is normal PR interval. Look at the next PR interval. It is little prolonged, more prolonged, even more prolonged, then dropped. Okay, again, normal PR, prolonged, 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 and dropped. So this is gradual PR prolongation before a P wave is dropped. So there is a cry of the PR segment before it is dropping a P wave, one more last P wave. So this is known as second degree block, but type 1, what we call as Wenckebach phenomenon. So Mobitz 1 block, also known as Wenckebach phenomenon. So this is commonly seen in inferior wall MI and sometimes AV nodal blocks. Okay, so I think there should be, I don't know why this, okay. Why this man had this block? You can see this. Yeah. So this man's heart block is, he doesn't need a pacemaker. Why? Because if you look at him, it is the right coronary artery infarction and with a big thrombus. So he had MI, and this is the thrombus suction, thrombus catheter. See how big it is there somewhere. The artery is blocked, and this is after thrombus suction and stenting. You see how big the artery is. Okay, and this is the sucked out thrombus. See, it is like an earthworm, right? So such a big clot is obstructing the right coronary artery. That was the mechanism, the cause, not mechanism, the cause of heart blocks. So MI with heart blocks, especially inferior wall MI, right coronary artery infarctions, wait, you need not put the pacemaker. On the other hand, this elderly man, so the earlier case requires only revascularization, but look at this man, elderly man, symptomatic, and what is happening here? One P wave is every second P wave is dropped. A normal PR interval. Look at, there is only one beat with normal PR interval. You cannot say it as morbid 1 block because you need some more complexes. This is 2:1 conduction. For 2 P waves, you have only one beat. For 2 P waves, you have only one QRS. Look at, whenever you see second degree block with normal PR interval, okay, morbid 2 block with normal PR interval, remember that's a serious disease, severe disease, infrahisian disease. Okay, but QRS is normal here, normal. And look at this, QRS is broad here. This is even more. Okay, in not only infrahis, there is also bundle branches. So left, this is left bundle branch morphology. Okay, left bundle is diseased. So all these are potential degenerative conduction system diseases in elderly persons if they are symptomatic. Even though not symptomatic, sooner or later they require pacemaker. You should ask for specific histories, even fatigue, heart failure symptoms. They are indication for pacemaker. So this is known as second degree block. 1%, that is some P waves do not go beyond the AV norm. Remember, first degree block, every P wave goes. Second degree block, some P waves do not go. Some P waves do not go. Okay. And look at this young lady. What is happening here? The QRS is very lower rate. And look at the P waves. Actually, there is a P wave here. If you see the calipers, I'll show that. Look at these starts. So there is a P wave as well as T wave here. Actually, P waves are regular and they are a bit faster. Normal. Look at this QRS. There is that is the P wave. The distortion is P wave because both P waves and QRS is diverged here. They beat on their own. So the stars are the P waves which are regular. The arrows are QRS. They are also regular, but both are dissociated. P wave rate is different, QRS rate is different. This is known as total dissociation. There is no relationship. Till second degree block, you have some relationship because this QRS is related to this P wave. This got married to this P wave, whereas here it is total divorce. Wife is on his own, on her own, husband is on his own. So this is known as complete heart block. Okay. So this is again, this can happen. So this is a complete heart block that is congenital in an young lady. So this is complete heart block in same inferior wall MI setting. Look at this inferior wall MI, but look at that P waves. P waves are exactly regular and not related to QRS. Look at that, stars and arrows. So inferior wall MI does not need a pacemaker, just treating the ischemia, removing the obstruction by stenting. Look at this, P wave. This is the T wave, but there is a P wave sitting on the T wave. This can happen. So you should always remember and never forget there is a small T wave that may sit on the, there is a small P wave that may sit on the T wave. So you should take into account that. This is very fine finding in the ECG. You should be able to recognize that means you are a cardiologist. So this is the typical feature of heart block, complete heart block. Look at this. This is QRS and T wave, ST segment, and there is a P wave sitting on the ST segment. Okay. So this is known as complete heart block, total dissociation. What is happening here? So severe complete heart block, heart rate is only 20. Only 20 is the heart rate. So gross that too, right bundle branch. Only left fascicle is giving the escape rhythm. Patient came with gasping and arrested. With these patterns, you may see elderly man And remember, so this man actually had hyperkalemia, severe acidosis, potassium was a 9 actually. So immediately he was intubated and went for dialysis. So remember non-cardiac cases as well. So in complete heart block, so no one goes, no P wave goes. Atrium beats on its own, ventricle beats on its own. So a total dissociation. So this is about heart blocks. Okay, in summary, every P wave goes to QRS, one-to-one relationship, but long, delayed is first degree block. Second degree block, some P waves are dropped, but before a P wave is dropped, if PR interval is gradually prolonged, that is known as grade 1, that is Mobitz 1 second degree block, also known as Wenckebach phenomenon. But regular P wave drops, more P waves are dropped without prolonged PR, that is normal PR interval is more advanced block, that is Mobitz 2 second degree block, and total dissociation is complete AV block. Remember, Mobitz 2 and third degree, they require pacemaker. So this, when I was in Nepal, in front of my room, I saw some 2 lovebirds. This is, remember this as normal rhythm, sinus rhythm, P and QRS. So when they fight, but still stay together, but staying a little bit apart is first degree block. But remember, they stay together, same house. And of course, they stay in same house, but gross. Sometimes the husband is leaving the wife, going out, and sometimes coming. That is second degree block. So third degree block is total dissociation. Both wife and husband divorced. They stay on their own, no relation. So that is total dissociation. And what do you call it? No pulse, asystole. Don't interpret the ECG. Try to save the patient because the patient is dying. So one word about the heart blocks, that is bundle branch blocks. So if you see M-shaped or W-shaped pattern in V1 with predominant R wave, that is right bundle branch block. So second wave will be dominant usually. The first wave is down, second wave is dominant. That is QR is also right bundle branch block, remember, but this is gray. This is due to, so this is known as, this is also right bundle branch block, but QRBB, which is suggestive of severe anterior wall MI with severe LV dysfunction. These patients are potentially under risk for sudden cardiac death. So right bundle branch block is usually benign, but this QRBBB pattern is dangerous. So they have the chance of sudden cardiac death. So they may need an ICD pacemaker if there is a severe LV dysfunction or VT. Look at this.
Guru sir, just 5 minutes more, sir.
Yeah. I'm finished.
Just a reminder.
I'll be finishing. So this is RBBB, but with what is happening, not only RBBB, PR is prolonged and there is axis change. There is significant right axis, L1 and AVL negative. So there is right bundle branch block, fascicular block, right axis is posterior fascicular block, and there is first degree AV block. So this is known as trifascicular block, which happens because of severe disease of the ventricles. This is gross cardiomegaly, cardiomyopathy, and patient requires CRTD, ICD implantation. This is left bundle branch block, wide QRS, but negative. Negative in V1 is left bundle branch block. Left bundle branch block can be normal sometimes, but you need to rule out left ventricular disease like this. In this patient, dilated ventricle and severe LV dysfunction, EF is only 24%. Patient underwent CRTD. Left bundle branch block with severe LV dysfunction requires CRT pacemakers. Okay, this is ST elevation, CAD, with CAD, coronary artery disease, I'm not covering. This is just to show one example. If you see these ST elevations, this is a potential emergency ischemic heart disease, and you should refer thrombolyze or refer to your cardiologist for primary PCA. So CAD I'm not covering because our topic is arrhythmia. So this is due to proximal LAD occlusion. Okay, a couple of slides of final arrhythmias. Young man with palpitation with this ECG. What is happening? Narrow complex, QRS tachycardia. This is known as a SVT. Regular narrow complex tachycardia is a SVT. If you remember this, the job is done. If you want more, so the drug of choice is IV adenosine for SVT. This is baseline sinus rhythm. If you compare potentially, because this is happening because of there is a short circuit around AV node. So this is known as AV nodal re-entry. If you watch carefully, look at this. In tachycardia, there is a cap in V1 that is typically absent in V1. If you're able to see my arrow. In tachycardia, there is small S wave in 2 and 3 that is typically absent in sinus rhythm. If you see this cap in V1 and SOX in 2-3 AVF, what I call it as Michael Jackson sign. This is not there in the books. This is only Guru Prasad's teaching. So the cap in V1 and the shoe, the socks in inferior leads 2-3 AVF is typical of AV NRT. Please remember this. AV nodal re-entry. Whereas if you see this sawtooth pattern in inferior leads, this is typical of atrial flutter. Atrial flutter. Similarly, if you see irregular QRS complexes, like classical undergraduate teaching, that is atrial fibrillation. This is what is atrial fibrillation. Okay, very fast. This is actually P wave. You don't see it on the surface ECG. This is what we see in electrophysiology lab. This is all the P waves. That's why they are absent on the surface. So small. You see only QRS. So these atrial fibrillations we can treat by ablation and getting them back to sinus rhythm. So this is young man. What is happening? But surgery, hydrocele surgery fitness. There is a broad complex. So that actually biseminal pattern. So this is ventricular biseminy. Young man arising from the right ventricular outflow tract. So I told you. So sometimes they may go into VT. They don't have ischemic heart disease. This is structurally normal heart. I told you. Any structure in the heart can give rise to arrhythmia. So this is the subvalvular infundibulum outflow tract that is based on calcium currents triggered mechanism can give rise to these currents, and we can identify those potential targets in the 3D mapping system, and we can ablate and cue those arrhythmias. So this is post CABZ patient, all broad complex tachycardia, all broad complex regular. Remember, if it is broad complex regular tachycardia, VT, and narrow is nice, that is SVT. Narrow QRS complex is nice, SVT, don't worry, give an adenosine. And if still sinking, BP is not there, shock it. So whether to shock or not does not depend on SVT or VT. It depends on pulse and pressure. If there is no pulse and pressure, give DC shock to either SVT or VT. If stable, treat. If stable, for SVT, give adenosine or amiodarone. For VT, if it is ischemia, give xylocaine, otherwise give amiodarone. This is what is broad. Any broad complex tachycardia is VT. Remember, narrow is SVT, narrow is nice, broad is bad, bad is potentially emergency. Okay, so this is it. So after ablation, they can be back. This is one more broad complex tachycardia. These are my summaries, okay? Any broad complex tachycardia, first diagnose VT. You are right, you are right, you are right. So this patient has actually mitral aneurysm. So most of the ventricular arrhythmias are treatable like this. So patient is back to sinus rhythm after ablation, of VT ablation because of some congenital mitral aneurysm. Okay. So arrhythmia is not just a phenomenon. It's not just a ECG finding. It's not just an electrical short circuit. It has its own brain. A lot of mechanisms are there, complex. So most of the arrhythmias are now treatable. Okay. So maybe pharmacological. If it is beyond pharmacological, still symptomatic, especially WPW syndrome and that SVT, that what I've shown, something like that, AVNRT, AVRT, that potentially more than 95% to 98% are curable. VTs, ventricular tachycardias, structurally normal heart, 95% curable. Even VT in MIs, post-MIs, they are 80 to 90% curable, including atrial fibrillation. So most of the arrhythmias are identifiable, treatable, and curable, majority extent. Thank you very much.
Thank you so much, sir. And I think it's a very excellent presentation. And we need hours and hours to hear your lecture, sir, because the time is limited.
Yeah, because the time is limited. maybe I cannot cover maybe sometime you can plan like bradycardia sessions, SVT sessions, VT sessions, especially for postgraduates or those who are interested. This is just a glimpse, what is possible in the field of arrhythmias. Okay.
Thank you so much, sir.
Thank you.
Now I'll like to invite the second speaker. The second speaker is Dr. Kaushal Tiwari. He is MD, MS in cardiothoracic and general surgery. He has done IMCS and a PhD in biomolecular research and fellowship in minimal invasive cardiac surgery. So he is a consultant cardiothoracic and vascular surgeon in ADK Hospital, Maldives, Mali. He is currently there only, and previously he was linked with College of Medical Sciences Teaching Hospital. His areas of interest are mostly surgical management of common congenital heart defects like EST, VST, AV canal defect, TOF. Similarly, mitral, aortic, tricuspid valve repair and replacements. Similarly, CABG and surgery of ascending aorta. He has significant experience in minimal invasive cardiac surgery and atrial fibrillation surgery, including radiofrequency ablation. Also, general thoracic surgery and thoracic trauma management and general vascular surgery. So with these remarks, I'd like to hand over this session to Dr. Kaushal Tiwari for his presentation.
Thank you. I think Dr. Guru has to stop his sharing. Professor Guru, can you just stop sharing your screen, please? Yeah. Okay.
And if you have any questions, usually to the registrants, if you have any questions, you can ask. And after this speech by Dr. Kaushal Tiwari, I will put the questions to the respective speakers.
Okay. Good evening. Good evening, everybody. Thank you, Dr. Sankar. Thank you, everybody, for organizing such an interesting webinar. Professor Guru's talk was really breathtaking. I revised my arrhythmia chapter, I would say. Yes, thank you very much. That's really very helpful for us also as a cardiac surgeon to revive the ECG, which we sometimes miss very much. So I'm talking about minimal invasive cardiac surgery, but before that, we know that heart itself, it is such an organ, and it was very much mentioned in a lot of literatures and poem and things, and it used to be a very sacred and sacrosanct and mysterious organ. And not only that, a lot of our colleagues, our fathers of the medicine, and they used to say that the heart, one of that Aristotle, which believed that heart alone is the viscera which cannot withstand any serious injuries. And that means that not only the injury, but also he meant that not any intervention in the heart was permissible. In 1983, Wilroth warned any surgeon who will touch the heart or try to suture the heart wound deserve to lose the esteem of his colleague. It was such a sacrosanct and such a mysterious organ that even surgeons like Wilroth and the physician like Wilroth was afraid of touching the heart and warning us not to touch the heart. So it was like cardiac surgery at that time. You can imagine it was just like a moving in a very strange and dangerous territory. So nobody were daring to work and do something with the heart. But there were some very courageous and brave surgeons, physicians, who, like, after only 3-4 years after the Wilroth's proclamation, I would say, Axel Kapelin from Norway, he dared to close the wound from a coronary artery damage from the stab wound in a person, but unfortunately the patient died. So there were very few heroic acts going on those days till Second World War, when during the Second World War, American Army Captain Dr. Henken, he used to repair a lot of heart trauma during the war, which ignited a lot of interest into the cardiac surgery, and especially after the you all cardiologists, we all know that there's a Blalock-Thomas shunt, there's a BTT shunt which was invented in 1944 to treat the blue baby syndrome. That was the real breakthrough in the cardiac surgery, and cardiac surgery seems to be started from that time. This was the beginning of the cardiac surgery era. After that, immediately after that, Walton Lidey, who was another colleague of Blalock, he was supposed to be father of open heart surgery, who in 1952 started the opening the heart and closing the heart defects, especially the atrial septal defects, through putting the patients to a deep ice tub and opening the heart into the deep hypothermic arrest. But there was a lot of risk associated with the hypothermic arrest, that patients used to get a lot of air embolism, and there were a lot of brain damage, strokes used to happen. Fortunately, in 1953, Gibbon, who developed the cardiopulmonary bypass machine, which helped us a lot, and the cardiac surgery after that really changed significantly, and a lot of things started to be performing, a lot of cardiac surgery started to happen after that invention of Gibbon's cardiopulmonary bypass machine. So by the time, from that time till now, even the heart was approached through mostly through the median sternotomy, that is dividing the sternum from the sternal notch to the gyphoid process, that we call median sternotomy. So you can see by opening the sternum, the whole heart is visualized. All the part of the heart can be seen and can be accessed. So any type of cardiac defect, any type of cardiac diseases could be treated by, and still it is possible to treat through the sternotomy. Extracardiac and intracardiac repair in the congenital heart disease can be done because we cardiac surgeons have a full control over the heart and the circulation and the oxygenation of the whole body. And because this is a conventional process and procedure, it has been practiced for more than 50 years. So comparatively, by the time this technology and this way of doing surgery has been simplified, and it has become very easier. However, if you see, if maybe some of you has met the patients with the post-cardiac surgery, post-sternotomy, they used to have a big wound. It's a really big wound because we have to open whole chest, whole sternum from sternal notch to the gyphoid process. So that gives a big wound, and obviously because we are dividing the bone, so there will be more blood loss, more pain, longer pain. I would say pain duration of the pain will be longer, as well as because there is a big bone which is fixing the whole chest cavity, whole thoracic cavity. So you can imagine that there will be some respiratory distress, respiratory dysfunction can happen, and there is always a possibility of wound infection, which in the case of sternotomy can be deep wound infection, because bone is very near to the skin here. There are no such muscles which are protecting the bone, so there is a very high risk of infection, especially the deep wound infection and sternal dehiscence. If it happens, it's a really disaster for the cardiac surgeons. If we have some cardiac surgeons, cardiothoracic surgeons in our audience, they might have seen some devastating complication of cardiac surgery, sternal dehiscence and instability, which take long time to treat it and to make the sternum stable and to make it heal. Obviously, even if there is no infection, so because of this big size of the wound, this is cosmetically non-appealing, and especially for the female and for young people, that is a little bit cosmetic discomfort is there. While you see the world has changing rapidly from very big size to small size. See the computer, first personal computer which was designed in 1946, around that 46, it used to be 27 ton, and it used to occupy about 1800 square feet. Comparatively now, you see, we have got a S10 mobile phone or Apple 11 Max Pro, whatever is the same size. It weigh only 160 gram, having 6.57 inches of screen, and that probably performs much more function than that 1946 personal computer which are 27 ton. Even the fashion, if you see, has been significantly changed. Like bikinis, swimsuits in the 1950s used to be covering whole body, while now swimsuits are like bikinis, which you can see. But even our cardiology friends, we have a lot of cardiology friends are here, who they have seen a lot of changes, a very rapid change in their stents, quality of stents, size of stents, the qualities of the stents has been changing very fastly. So due to that, the rate of the PCI, which cardiologists, interventional cardiologists are doing in the MI cases, has been rapidly increased in the last decades. You can see it was in the 90s, it was almost the same percentage, while it has gone rapidly up because of the innovation, because of the change in the quality and the size things. So actually, we cardiac surgeons, maybe it's a joke as well, that we have to be very careful that our cardiologist friends are very near, if not they have already overtaking us in all the cardiac treatments. So starting from TAVI, mitral clip and percutaneous mitral valve replacements, things are coming, and our cardiology friends are almost overtaking us as a cardiac surgeons, cardiothoracic surgeons. It's because we are probably to blame for it. Our armamentarium, I would say, our instruments from the 1950s, if you see, it was in the black and white color photo, and now it's in the 2020 is a color photo. The difference is the only color of the photo, but the instruments remain almost the same. So because the instruments, because the innovations are very less, so most of the surgeries are invasive, and these are the invasiveness which scare the cardiac patients. So you can see the wound size, how big is that, is occupying whole chest. This is the thing which most of the patients, they are afraid of going undergo surgery. So we as a cardiac surgeons has to realize the truth. Yes, we are lagging behind. If we do not realize this truth, then we will be left behind in this race of minimal invasiveness, minimal things going on, not only in the cardiology, but also all over the medical sciences. So we have to start doing open heart without a big opening, I would say. Without opening we can't do, but we can do without big opening. So you can see the difference between the sternotomy and doing a surgery with a small thoracotomy. It's almost 20% of the size. So if you see the cardiac surgery OT, in the beginning of the era, it used to be like this, while now the cardiac surgery OT, operating theater, looks like this. It's a hybrid as well as robotic cardiac theater. So what is MICS? After the 1996, firstly the Cost Group reported first case of doing minimal invasive mitral valve replacement. So it has been modified by several means. So 2003 Society of Thoracic Surgeons database say that any procedure performed with or without full sternotomy and with the cardiopulmonary support. 2008 American Heart Association statement says that the small chest incision that doesn't include exclude the full sternotomy, and definitely will be use of bypass or without bypass. So why minimal invasive? That is, understandable. It is less invasive, which is very important. It should be safe and reproducible to be used in the mass scale to more or less to replace the midline sternotomy, which is being practiced in many tertiary care centers in the developed countries like in Europe and the US. It allows faster independence ambulation. That helps in quicker recovery, quicker return to the work. That is very important for the economic matters as well. Obviously, if there is no bone dissection, no bone division, no bone wound, so there will be no devastating external complication, which I already explained as a devastating, and that's really very, very cumbersome. Definitely, the better cosmesis is one of the main charm in the minimal invasive cardiac surgery. But there are always a lot of challenges involved. Challenges starts that we all been trained, and most of our colleague and we all are trained mostly by the conventional cardiac surgery. So to shift from the conventional cardiac surgery, we need to go specific training in the minimal invasive cardiac surgery. Before doing any minimal invasive cardiac surgery, after training even, you need a very appropriate planning. Planning of the patients, selection of the patients is very important. Plus, a center must have very well-trained and energetic team member who is capable of managing, dealing with the complications arising during the beginning of the minimal invasive cardiac surgery program. Definitely, to do any minimal invasive cardiac surgery, we need a transesophageal echocardiography available, and a person, cardiologist and cardiac anesthetist who is capable of doing perfectly transesophageal echocardiography. Although this transesophageal echocardiography has become mandatory in even conventional surgery, but in minimal invasive cardiac surgery without TE, it is almost impossible to do. Plus, as I said, that our armamentariums are still the old, but now some innovations are going on. So for the minimal invasive cardiac surgery, we need special instruments, specially designed, long, with a special technology, with special way of functioning. Special retractors are being invented and being used, as well as to put the patient on the cardiopulmonary bypass machine, heart-lung machine, what we used to call. We need a specific cannulas, which are slightly expensive than the conventional cannula, but they are really useful and they are the main requirements. From the surgeon's perspective, obviously a surgeon has to willing to learn a new technology, which is really new to start from. Starting from the looking at the things is always different, because when we open the sternum, we see the heart from above and we see everything very clear, while we have to when we are looking from the down, like overlooking and underlooking, you see this one, the perspective will be different. And then after you know the skill and you are trained, then there will be confidence to do it. Then that is very important to have a hand movement. Hand skill is very important in the minimal invasive cardiac surgery, because all the instruments is been modified and the way the instruments are working is completely different than the way the conventional instruments works. So the hand movement is another thing. Endovision I already said, because most of the cardiac minimal invasive cardiac surgery has been used by the port access with the video camera assistant. Definitely, because we are using a lot of instruments and cameras and robots, so there will be least assistants, and there is almost sometimes there is no use of assistant to do one cardiac surgery. So the goal of the minimal invasive cardiac surgery is small incision, so not more than 5 to 7 centimeters, which should provide a good exposure to the surgeons, to the surgery what we are going to perform. And it should provide identical quality as compared to the full open heart surgery. If there is a simple compromise in the quality and the repair or the replacement or the quality of the work done, then that is not acceptable. So that is very important thing. Similar cost, but in the initial phase of the establishment of the minimal invasive cardiac surgery, hospital has some more investment, but because the recovery is faster, because the hospital stay is shorter, so the economic things will be more or less equal and more or less similar at the end of the day. During the surgery, yes, operating time and bypass time, what we use should be equal, and usually in the very beginning of the surgery, it used to be a little bit higher because there is a learning curve, but it becomes equal. So basically, minimal invasive cardiac surgery by the minimal invasive, any type of cardiac surgery can be done, starting from the congenital basic congenital heart defects, as well as all the acquired heart disease can be done at the moment. So, but we must understand and we must take in account what are the contraindications when we should not do the minimal invasive cardiac surgery, especially when there is a cardiac emergencies, when there is a acute MI and the patient with a very severe LV dysfunction, patient is in shock. Minimal invasive cardiac surgery should not be practiced. However, I have seen in few centers in Europe, they are more capable, they can do, but it's not advisable to do. Patients with the diffuse peripheral artery disease are contraindicated because of the fact that we do bypass, we put the patient on the bypass machine through the peripheral arterial cannulation, so that sometimes is difficult. It increases the risk of stroke and the more complications, so that is not advisable. As well as morbid obese patient is a contraindication. If you go during the workup and a specific thing during the mitral valve surgery, if the valve is extensively calcified, there's a full of thrombus in the left atrium, there's a big, sometimes actually big LA is a benefit for us, but usually we know that if there's a big giant LA, there is a risk of thrombus, so that is sometimes a contraindication. Aortic surgery, similarly, is a very small aortic root. There might be a possibility of extension of the aortic root, so that procedure is a complicated procedure, so it should not be tried in that things. ASD, if there is a congenital atrial septal defect with the PAPVC, then they need more extensive repair, and so that is not advisable. As well as during the CABG, if there is more than 4 grafts, it is not advisable. However, I have seen even putting 5 grafts in big centers, very experienced centers. If there is an intramyocardial vessels, especially if the PDA and the right arteries are intramyocardial, usually it is not advisable. Plus, a patient with a severe COPD, it is not advisable because we are doing most of the cases with a single lung ventilation. So if a patient already has compromised ventilation, that will be complicated. What are the surgical approaches? What we are using is mostly the thoracotomy, right-sided or left-sided. Right-sided thoracotomy is mostly reserved for the mitral valve replacement, repair, aortic valve surgery, tricuspid valve surgery, and congenital ASD, VSD repair. While left-sided is for mid-cavus, minimal invasive coronary artery bypass grafting, as well as for the TOF ICR repair. So what are the advantage is actually during the thoracotomy, it has got excellent result. The final clinical result is excellent because very small wound, less damage to the bone tissue, less damage to the big muscles, and less bleeding is there. Patient prefers it because the wound is almost not visible because of the clothes, and especially it's excellent for the female that can be not visible because we enter through the submammary fold. Disadvantage is this surgery needs long instruments, and if in the case of emergency, converting the patient to the sternotomy sometimes is a cumbersome. The other access is, which was initially practiced, still practiced, is the mini sternotomy. Usually it is done up to the second intercostal space, is a small 5 to 7 centimeter incision from the upside or the downside, and that allows very good exposure, especially to the mitral valve, sometimes to do some bypass, coronary artery bypass, and it's a very good access for the aortic surgery as well as Benter. Advantage is also, I said, this is a good exposure. During the minimal invasive cardiac surgery, all the cardiac surgery has got a specific cardiac anesthesia requirement, but when it comes to the minimal invasive, this requirement increases, and the skills and the prerequisite is different than slightly different than the conventional cardiac surgery. We almost put in every patient double lumen endotracheal tube, so that
Dr. Kausal, 5 minutes more.
Yeah, I'm finishing. So that it will be single lung ventilation. T is already, I told you, is important. So during the surgery, the positioning of the patient is important. We put some elevating the thing, and we prepare the inguinal region so that we can cannulate the femoral vessels. For the bypass, coronary artery bypass, we go through the left side. I told you this is the position how we do. And in a country like ours, in a developing countries where not all the expensive instruments are not available, even we can do the CABG procedure with the normal instrument available, octopus and things which is available in every hospital. So you can see patients undergone mitral aortic valve replacement with a small anterior thoracotomy at the second intercostal space. It is just 5 to 7 centimeters. Same is only the difference is the incision is at the third and fourth intercostal space. The ASD and VSD repair patients also same right-sided 3 to 4 fourth intercostal space, 5 to 7 centimeter of incision. So there are a lot of articles, there are a lot of research going on and articles coming up doing even the complete total arterial revascularization can be done through the mini invasive cardiac surgery. This is I have published recently this article, and you can see not only that, not only the traditional conventional fresh mitral surgery, also redo mitral surgery in a patient who has undergone coronary artery bypass graft can be done successfully and nicely through the mini invasive surgery, as well as atrial fibrillation surgery. Dr. Guru was talking in the case of AF and things, the ablation, catheter ablation, as well as during the concomitant cardiac surgery like CABG or valve surgery, even the ablation for the atrial fibrillation can be done through the minimal invasive thoracotomy, as well as not only thoracotomy, even if it is a lone atrial fibrillation. There are several studies which shows that thoracoscopic surgical ablation is superior to catheter ablation in the atrial fibrillation treatment. So just a small video how we do a case of mitral replacement by minimal invasive. You can see where the right-sided thoracotomy, 5 to 7 centimeter mini thoracotomy. This is just at the fourth intercostal space. It is already the pericardium is open. You can see the heart beating there. After opening the heart, after seeing the heart structure is okay, then we go for the femoral vessels cannulation to put the patient on the bypass. This is a cannulation procedure with a special cannula which are available for the minimal invasive. After cannulation, we go on bypass and we clamp the aorta. Then we open the. This is the clamping of the aorta through a small incision at the axillary region. Now the heart is stopped. So we are opening the LA. So the LA is open. You can see very nicely the mitral valve, how nicely it is visible. Mitral valve is resected now. You see the all except the posterior leaflet left there. Is putting the mechanical valve. If you see the instruments are completely different than the traditional instrument. This is the valve prosthesis in. Now, if you see how we are tying the knot, one stitch is on the hand, and another is a knot pusher, which is not been used in the traditional conventional surgery. So these are the few instruments which makes difference. Now LA is closed, surgery is almost finished. just a chest tube. So, in conclusion, I would say in this modern age, and things has been changing from from major to minor. Minimal invasive cardiac surgery is safe, is less invasive, with the same cost, with the significantly less blood loss in the patients. This is a reproducible with the excellent outcome. I would say faster ambulation allows the patients to be discharged faster, with the very less risk of deep wound complication, and it's very good for to harvest the bilateral intermemory artery, especially even in the diabetic patients, which allows total arterial revascularization for the MI patients. Obviously, that gives better cosmesis, improve quality of life, but it all comes in a cost of surgeons' hard work, because surgeon has to suffer during the surgery. As Arzenziano said, that the minimal invasive cardiac surgery transfers the pain of the surgery from the patient to the surgeon. Obviously, patients has got less pain, but during the surgery, we the surgeon who has got the more pain. Thank you.
Thank you, Dr. Kausal, for your nice presentation, and you have nicely focused on the minimal invasive cardiothoracic surgery and the shifting pattern. Now, without delay, I would like to request Dr. Chandramani Adhikari for the presentation. He is a cardiologist at Syed Gangala National Heart Center, and recently is also the director of the Syed Gangala National Heart Center. He is associate professor in cardiology in NAMS. Similarly, he is a supervisor for the FCPS students. He is general secretary of the Cardiac Society of Nepal, and he has dozens of clinical and research articles, including coronary intervention and congenital and structural intervention. And I'm very proud to say that he has shaped and is mostly focusing on the structural heart disease, and is trying to cover and a little bit replace the conventional surgical closure of the structural heart disease. I think you will be focusing on this. And thank you, Dr. Chandramani Adhikari, for accepting our this invitation. And I'd like to request you for the presentation.
Thank you, Dr. Shankar, for your encouraging words. So I think Dr. Kausal has made my presentation a little bit easier, because he spoke on minimal invasive surgery for structural intervention. So my topic is congenital and structural intervention in Nepal, present and future. I'll be talking on what we are doing in Nepal. I will be talking on the development in National Heart Center as well as other centers in Nepal. So what is congenital and structural intervention? It's you can say that it's an alternative procedure for invasive surgical procedure. It's a minimal invasive. You can say that it's non-invasive also. It's safe and effective. So you can see the difference between the surgical closure, that is the conventional one, and the device closure. In the surgical closure, you can see a big wound, and then in device closure, you don't notice any such wound. There will be small puncture at the inlingual region, and nobody can notice this scar. So that is the benefit of this procedure, congenital and structural intervention. And second thing is this procedure is done for the beauty also. So though the surgeons came up with a minimal invasive procedure, but there will be scar on the chest. But with device closure, there will be no scar in the chest. And it's very important for the young girls, especially in the third world country, where the ladies with a small scar in the chest, it will be very difficult for them to have a good life, especially for the social life. So what does congenital and structural intervention includes? So it can include the valvular intervention like valve repair techniques, balloon valvuloplasty, valvular leaks closure, transcatheter valve replacement. In congenital cases, it's arterial septal defect closure, ventricular septal defect closure, closure of PDA, intervention treatment of coarctation of aorta, closure of fistula, and structural intervention include closure of PFO, left atrial appendage closure, closure of post-myocardial infarction, ventricular septal defect, and intervention technique to treat heart failure. So all these techniques, except from the coronary intervention, all those interventions which we do inside the cath lab comes into the congenital and structural intervention. So the congenital and structural intervention is a vast subject. A lot of things comes under this roof. When we talk about congenital and structural intervention in Nepal, I can just go through two of the publications from outside Bengal National Heart Center. So one was from Journal of Chitwan Medical College. It's an original research article done by Dr. Regmi and their group. It's about balloon mitral valvuloplasty, BMV, and early experience in Chitwan Medical College. And the other one is transcatheter closure of atrial septal defect with Amplatzer device in adolescent and adult, short-term result from Monmon Cardiovascular and Thoracic Center from Kathmandu. These are the only two articles I got from apart from Gangalal. We have a few publications on this congenital structural heart intervention, but apart from Gangalal, these are the only two publications I came across. But there are case report of PTMC, device closure of AST PDF from BP Koirala Institute of Medical Sciences, Norwich Hospital, Nobel Hospital, and other hospital in Kathmandu and outside Kathmandu. The most of the experience of Nepal in terms of congenital and structural intervention comes from National Heart Center. So let's talk about a few of the intervention that is quite popular or quite successful in National Heart Center as well as in Nepal. That is percutaneous transmitral commissurectomy for mitral stenosis, this PTMC. In this publication in Nepalese Heart Journal in 2016, till 2016 June, 6,000 PTMC were done in South National Heart Center, and probably till 2020, more than 7,000 cases of PTMC were done in the National Heart Center with a very good result. Not only that, we have done this PTMC in a different category of patient with good results, just like PTMC in children, PTMC in juvenile mitral stenosis, PTMC in elderly, which means that the patient who are aged more than 60, PTMC in pregnancy, PTMC in special condition like when the patient had LA clot and the PTMC was successfully done. So what it suggests that the experience of PTMC in Nepal is very good. We have a very good results. It's comparable to the international studies. And apart from PTMC, AST device closure is also a safe and effective option for ostium secundum AST. You can see here the study from Canada shows that the number of surgical closure of AST has gone down significantly, whereas the transcatheter closure of AST has gone up. You can see from 1998, the number of transcatheter closure has gone up significantly in Canada. Same is the story in National Heart Center in Nepal also. The number of device closure of AST has gone up, while the surgical closure of AST has gone down. So this clearly suggests that the development of AST device closure in National Heart Center. When we started this service in 2007, we used to do less than 30 till 2015. From 2016, the number of cases has increased. In 2016, we have done 123 cases. In 2017, 160 cases. In 2018, 251 cases, and 2019, 245 cases. And in February 2020, we have completed around 1,000. We have completed 1,000 AST device closure in the center, and the number of AST device closure in a single year of more than 200 makes South National Heart Center one of the busiest center even in the South Asia to do this much of cases in a single calendar year. So what we have changed from our previous experience and our research experience. So from 2007 to 2015, we did few number of cases. Most of them were done under general anesthesia on transesophageal echocardiography guidance. But from 2016, we have changed our policy, or we have changed our way of doing AST device closure. We have done around 780 cases in those 2016 to 19, and most of them are done under local anesthesia, under transthoracic echocardiography. What is the benefit of this is we can complete the procedure within 10-15 minutes, and the patient will go out immediately after the procedure. So the whole procedure will be over by 15 to 20 minutes. So it makes the procedure easy. It's made the cath lab team comfortable that patient, there is no need of anesthesia also. So when we do AST device closure in our cath lab, we don't require anesthetist. We just complete the procedure without the help of the anesthesia. So it makes the procedure very easy and comfortable for all of us. So when we talk about this AST device closure, we have a very good success rate. So during those period from 2016 to 2019, our success rate was 98.4%. Most of the cases were done under local anesthesia, under transthoracic echocardiography assistant. And then we have a very less complication, and this was our publication. The most common complication was transient ST elevation in the inferior leads, that was present in 2.6%, pericardial impedance in 0.7%, and cardiac arrhythmia in 0.5%. So we have a very good success rate with less complications. So that makes that our procedure is very good. Our success rate is very good, and the complication is very less. We all know that previously PDA used to be closed by the surgeons, but surgical PDA closure is associated with significant risks, especially rupture of the PDA during the surgery, especially in the adult, is a very fatal complication, and recurrent laryngeal nerves injury during the ligation result is the hoarseness of voice. These two are the very bad complication of PDA surgical closure. And because of the reason in ASC guideline in 2010, what they said, device closure is the method of choice, even if the cardiac operations are indicated due to the other concomitant cardiac lesion, and can be successfully performed in the vast majority of the adults with a very low complication rate. And surgery is reserved for the rare patient with the duct too large for device closure and with unsuitable anatomy such as aneurysm formation. So what they suggest is PDA device closure is the preferred choice for all type of PDAs if it is possible. The PDA device closure experience in Said is same like what we are experiencing in AST device closure. You can see here from 2007 to 2015, our PDA device closure cases were less than 40, less than even 20. But from 2016, our number has increased a lot. So every year we do around 100 plus cases in a year, and recently we have completed 500 successful PDA closure in National Heart Center. So when we talk about the congenital structural intervention, VST device closure is one of the toughest intervention, transcatheter intervention for the intervention cardiologist. And transcatheter closure of VST as an alternative to surgery has gained increasing acceptance due to the comparable success rate and low complication rate. This approach has several advantages, such that it can avoid the hysterectomy, avoid the cardiopulmonary bypass with less pain and no scar and shorter hospital stay. You can just imagine after closing a VST, the patient can go home next day without any medications. You can see this PDA device closure we have done recently. You can see that this is the LV angiogram. There is a PDA. We close with the PDA device closure, and then we release the BST device closure. Is a little bit difficult procedure. It takes a lot of time because of the lot of small procedures we need to do to make this procedure successful. We have published our initial experience of BST device closure, and we have a success rate of 90. With the increasing experience, our success rate may go up, and we have very less number of complications. So we think that with the initial experience, if we are having 90% of success rate, then our program is really doing good. So these are the things which we are doing presently, which we are doing in regularly in National Heart Center. So what is the future in Nepal in congenital structure intervention? We have a lot of things to do, just like PFO closure, LA appendage closure, rupture of sinus of valvular closure, coarctation of aorta, device closure of post-MI VSR, transcatheter palavalvular leak repair, transcatheter sinus venous ST closure, and TAVI. I'll be explaining just in 1 or 2 slides. So we all know that PFO closure, stroke in US is 30% of them are cryptogenic stroke. I think most of you understand what cryptogenic stroke means, and in up to 40% of the patient they have PFO. So there are 3 randomized trials of GO, reduce, close, and respect. They show that if we close the PFO with a device, then the patient will have less stroke compared with the medical therapy alone. So because based upon this, we can, in those patients who have a cryptogenic stroke and have a PFO, those PFO can be closed and they should be closed. And we all know that many patients of AF, they can develop stroke, and the problem with the prevention of stroke in AF patient is that we need to anticoagulate or we need to use warfarin, and we all know that it's very difficult to monitor that their PT-INR because of the social economic condition, as well because of the geographical problem. Many patients, they cannot afford to take warfarin because of they cannot monitor the PT-INR, and we know that there are newer drugs in which they don't need to monitor the PT-INR, but they are really expensive. And also there are some other issue with the warfarin also, that it has a very narrow therapeutic window, needs for close monitoring, and various diet and interaction is there. And there is a new option that we can close the left atrial appendage, because 90% of the clot which causes stroke in AF are developed in the LA, and if we close that LA, then the patient won't develop stroke. That is the basic reason behind closing the LA appendage. Though the indication by European Society of Cardiology is 2B, only in those patients who have high risk, stroke risk, and contraindication for long-term anticoagulation, those patients can be treated with this therapy. But based upon our country status, because most of the patients, they cannot afford the NOAC, and it's very difficult to monitor the PT-INR, and it's very difficult to prescribe warfarin in the country like Nepal. This LA close can be a viable option in the near future. And we all know that RSO is to be treated with a surgical closure, but this can be closed with the device also. The procedure technique is same like the VST device closure. If an intervention cardiologist can close a VST with a device, okay, they can also close the RSOV with the device. That is almost similar procedure. The only thing is that the VST is inferior to the aortic valve, whereas the RSOV is above the aortic valve. The device, then coarctation of aorta, which is previously used to be a surgical procedure, now it can be treated with a transcatheter approach. There are other things just like post-MI ventricular septal rupture. We all know that this is a catastrophic complication of acute MI. In Surgical National STMI registry, the VSR incidence was 0.2%, and mortality is 90 to 95% within 2 months without intervention. Surgical closure is the definite option, but the outcome is very, very bad. So this VST can be closed with the device. We use post-MI VST device or an AST device. It's a simple procedure like what we do for VST closure. And then we are doing a lot of valve surgery, and patient can develop the palavalvular leak. This palavalvular leak can also be treated with the transcatheter approach. There are a lot of success stories, successful case report in the literature. So we have yet to start this service. And also the most interesting is transcatheter closure of sinus venous AST. We used to think that sinus venous AST is a contraindication indicated for the device closure, but it's not the true. So many case report of successful closure of sinus venous history with a transcatheter intervention. The only thing is that it is closed with a cover stent, which is easily available in India. Not only that, there is a lot of interest in TAVI. In Nepal, it's yet to be established, but we are really interested to start this service in the country, because we all know that there are few patients they are going to India and other country to get this service, but we in National Heart Center are ready to start this service if we get patient. And in conclusion, congenital and structural intervention are semi-invasive alternative procedure for surgeries. Intervention are available in the country with good results, and we'll still need to start and develop some interventions like TAVI, RSOB closure, sinus venous CCST transcatheter closure, pulmonary parabolic leak repair, and all which I mentioned earlier. So thank you once again for giving this opportunity to talk on congenital structural intervention in Nepal. Thank you.
Thank you, Dr. Chandramani, for an excellent presentation. And I think we are very proud that you have been doing excellent job in structural heart disease in Nepal. And I wish you all the best, and especially from National Heart Lung Society. We want more and more works on structural heart disease. And I'd like to thank all the speakers who accepted our invitation and made this seminar a grand success. And I'd like to thank the CIPLA Nepal for supporting this webinar, and especially Devashish sir, who took great pain in initiating it and following all the speakers and make it a grand success. And finally, I'd like to request Dr. Any questions? I did not get any questions so far. I think they have understood very nicely about the topics. So I'd like to request finally Dr. Samras Regni to put his concluding remarks, and then hopefully we'll meet in the near future. Thank you so much.
Thank you.